Good morning, everyone, and welcome to day 2 of the McLean Technology and Psychiatry Summit. My name is Ipsit Vahia. I'm the medical director of the McLean Institute for Technology and Psychiatry, and I'm also the associate chief of geriatric psychiatry at McLean Hospital. We're really excited to be presenting this panel to you called Emerging Applications for Immersive Virtual Reality for Mental and Cognitive Health. Our speakers today will be Dr. Ian Moore, Dr. Amie Preston, Dr. Harmehr Sekhon, and Dr. Trueba Yepez. I will serve as the moderator. Over the next hour and a half, we will hear presentations from our 4 speakers, after which we will move to a moderated discussion. Please use your question and answer boxes at the bottom of your screen to put in any comments and questions. I will be monitoring this, and our speakers will be looking at this between talks as well. They may answer some of the questions in the text box. Other questions we will try and answer live at the end of the session. I apologize for some background noise, but I will stay mute. Our first speaker today is Dr. Ian Moore. Dr. Moore is a neuropsychology fellow at the Central Arkansas VA healthcare system. And he will be speaking to us today on initial tolerability of immersive virtual reality in older veterans. One note I want to add before I hand over the mic to Dr. Moore is that our session today represents in some ways the evolution of VR from this aspirational technology to something that has become a tool with everyday application already beginning. Our speakers collectively will discuss its use in academic clinic settings, in the VA healthcare system, in more community-based environments. And we will have presentations of work being done in the East Coast and the Central United States, in Canada, but also in Ecuador. So really VR has gone from being something where we're thinking about the weather to figuring out the how of how to use it. And it's gone from being something that we think about for younger adults because they may be more native to these technologies to using this with older adults that may not be as familiar with VR. And yet, I think our 4 speakers will demonstrate that this work can be quite easily accomplished now. Hopefully, it will spark some ideas and discussion, and we will all leave this session with some things we would like to maybe try out. With that, Dr. Moore, you have the floor.
Thank you very much, and good morning, everyone. So as part of my study, I am going to be doing a little bit of an overview of the field as well that does kind of touch on each of our aspects of each of our studies respectively. So without further ado, I will go ahead and jump into that. So a little bit of background on the emergence of immersive virtual reality in healthcare settings. More and more, we're having research being done on the increased accessibility and utilization of virtual reality technologies in healthcare. And specifically, it's demonstrated a lot of usefulness in the treatment of mental health disorders, such as anxiety disorders, PTSD, phobia disorders, social anxiety disorders, depression, and schizophrenia. And evidence is also beginning to emerge that suggests that it is an intervention for the treatment and management of neurodevelopmental disorders, such as autism spectrum disorders, as well as neurocognitive disorders, ranging from mild cognitive impairment to major neurocognitive disorder. Regarding the neurocognitive disorders, IVR interventions have shown modest effectiveness in improving cognitive and emotional functioning and functional abilities in those with MCI and major neurocognitive disorder, with the effects being greater for MCI. And regarding cognition, IVR interventions have demonstrated modest effectiveness in improving visual spatial functioning, memory, and executive functioning. Also, emerging evidence suggests that IVR is useful also for physical and cognitive rehab purposes, including showing modest effectiveness in compared to standardized treatment protocols for improving strength and gait improvement, and smaller effects with motor control and balance. And also IVR has also been started to be used for patient and provider psychoeducation. Although this research is limited, it does have promise for showing how we could potentially communicate results of our results of our research and clinical care to patients, caregivers, and other professionals working in the field. So a little bit of information on the feasibility of virtual reality. Overall, IVR interventions have been shown to be feasible and well tolerated across different clinical populations and care settings and with different patient populations. Overall, they've been successfully implemented in both inpatient and outpatient care in both medical and psychiatric inpatient units, as well as both short and long-term residential care units. Majority of studies for most patients have reported minimal adverse side effects associated with IVR use, although to date, much of the research in that has been done with younger able-bodied adults, so it's a hole in the research this group is hoping to address. Although most patients across research have reported high levels of satisfaction, including increased positive use towards IVR, especially after their first exposure. And this is including some initial hesitancy that's also overcome after they're exposed and have some reps with immersive virtual reality. And so most characteristics impacting IVR acceptance in research were age, education, and computer knowledge with technology specifically. And those factors were mediated by age, intelligence, and technology anxiety. Age had the most strong initial negative association with immersive virtual reality engagement, but those effects were reduced greatly after initial exposure. So what are some barriers that are related to immersive virtual reality use? I'm not going to touch too much on the first one because we have another presenter going over that, but a big one is affordability and accessibility, with the prices ranging vastly. For standalone headsets, anyways, they can go anywhere from $300 up to $1,500, and that's just for the headset. That's not even including other technologies you may need to operate these things safely and effectively. So this kind of can limit their sales to individuals of higher socioeconomic status and to larger organizations and hospital systems. So additionally, there's also the technology hesitancy and illiteracy, especially amongst older adults, which can be a significant predictor of pre-IVR use attitudes. But as I said, these attitudes do significantly improve after exposure. You can also have sociocultural attitudes that can impact people's views on technology and hesitancy to use technology in various groups. So also, given that IVR is in its infancy, content availability can also be limited. So there is still a growing number of people that are actually producing the content that we use for our studies on virtual reality, and those are continuing to get better, although depending on what unit you're using, that what you have access to content-wise can change, both in quantity and quality. So this is a limitation of the field that will be addressed as this continues to expand, but right now it's notable. And then also finally, most IVR needs a certain level of what's called game capital. So acquiring common game norms, skills, knowledge, and hardware to be successful in using virtual reality. So for instance, controllers can be difficult for novice users to use, and some technologies such as the Oculus Quest have attempted to address these by using hand controls. And this is a good idea, but the execution is a little lacking, especially for those with poor dexterity or motor control problems. The hand controls still don't work very well. So kind of increasing game capital people's will happen through increased knowledge of the technology and exposure to it as well. So what are some of the most common adverse effects impacting the tolerability of virtual reality use? Well, the big ones are headache, eye strain, perceptual motor after effects, and simulation or cyber sickness. Those terms are used interchangeably in the research. So regarding perceptual motor after effects, this is basically an after image that happens either when patients' eyes are open or closed, where they kind of still have a perception of the things that they were seeing during their virtual reality experience. And this can be stressful because in certain patients, it can last minutes to hours depending. However, this is one of the things that is reduced greatly with continued exposure to virtual reality environments. Additionally, including this, cyber sickness and simulation sickness, I would say, is probably the most well-studied side effect. And this includes things like nausea, vomiting, eye fatigue, dizziness, ataxia, and some more gastrointestinal distress symptoms. And it has been found in the research to occur between 25 and 95% of virtual reality users after first time use. However, this is drastically reduced after continued use, with reduction in symptoms being most pronounced after 3 to 4 sessions. One of the biggest research points that is under addressed but needs to be is older adults may be more vulnerable to cyber sickness at baseline due to health conditions that they have that promote increased dizziness and discoordination, as well as medication side effects. However, there's research is only just beginning to kind of look into VR with older adults. So there are several theories on cyber sickness, including what content you use, with lower resolution content, or that with a lower frame rate being implicated in higher simulation sickness, as well as immersive, fully immersive 360 virtual reality environments causing more simulation sickness than more 2D related environments. Also, you have a discordance between the movement that you see and the movement that is experienced by your body. So for those people who are using virtual reality and seated and not moving, there may be more cyber sickness in these individuals due to the conflicting information between what their eyes are seeing and what their body is experiencing. So there's some initial research to suggest that getting people up and moving during virtual reality can actually reduce some of this cyber sickness. Additionally, another big one is exposure time, with a lot of studies finding that anything over 20 to 30 minutes is associated with greater cyber sickness, especially in older adults. But this increased exposure over time will reduce this and actually lengthen the amount of time in initial research that somebody can stay in virtual reality before symptoms happen. And the final thing is possibly there are some sex differences with higher simulation sickness being noticed in females, but the research is not necessarily consistent at this point and needs to be delved into further. So what are some contradictions to immersive virtual reality use, at least as we understand it today? So monoocular vision, seizures, severe vertigo or vestibular impairments, disorientation, severe simulation sickness at baseline, and a high risk of falls or an injury risk at baseline are all pretty much some big exclusionary criteria that the research has identified. And some notable precautions, not necessarily that will exclude people, but you need to keep in mind, are poor head and neck strength, because the headsets can be quite heavy, several pounds for some of them, especially the ones that we're using here at Cavus are quite heavy. And it can also exacerbate other health conditions that are underlying, including increased, because there are some increased physical strain depending on the apps you're using and the things you're having them do. Some individuals, especially on the VA side, this one is salient, that are prone to overstimulation. So including individuals with PTSD or that are highly easily startled. You need to consider what types of things you're engaging them in, because it can be triggering to some folks. And then, as I said before, prolonged usage, especially with certain patient populations, can really exacerbate some physical symptoms. So what are some of the shortcomings of the current research that we do have? Well, first up is most tolerance studies have been conducted with younger and or healthy patient populations. A lot of the research has kind of shied away from older patients due to physical and cognitive difficulties, as well as technological hesitancy and perceptions about technological hesitancy. A lot of research has kind of addressed that people will maybe stay away because they don't think that older adults would either be willing to or able to engage with technology. But as myself and my colleagues can get into, and research we have found as well, that's actually not the case. And once you kind of overcome that initial reservation and really work with the patients to understand how to use the technology and the purpose of it, they actually enjoy the experiences quite a lot. A lot of previous research related to tolerance and specifically related to physical symptoms has relied on patient self-report, mostly is the simulation sickness questionnaire, which I believe every single one of us is using. It's kind of the benchmark in the field as far as reporting of symptoms, but there hasn't been as much research done on physiological symptoms known to be predictive of increased or poor VR tolerance, such as heart rate, blood pressure, galvanic skin response, and gait and postural instability or changes before and after use. And finally, limited research is also done on symptom persistence and alleviation of the symptoms. Generally, there is an understanding that symptoms do go away after repeated exposure, although the research has shown that the timeline is variable for how long symptoms persist after exposure, how long they persist after repeated exposure per session, and even further research is lacking in the ways to alleviate or reduce these methods, especially after symptom onset. So that's an area that needs to be addressed. So this kind of brings me to my current study. So the goals of this project that I am undertaking is to evaluate both the prevalence and severity of cyber sickness and other physical symptoms in older adults after initial IVR exposure, as well as to gain information on their own perceived experience, whether they liked it, what they liked and what they didn't like, and what they would change about the VR process and procedures that I've enacted for my study. And then also to develop and implement virtual reality procedures for reducing and eliminating adverse physical side effects caused by virtual reality use, both over time and initially after exposure, so both in session and after session. And then long-term, I want to assess and increase the patients' tolerability of virtual reality, as this is important for developing more robust virtual reality-based treatment protocols. We kind of want to break through that wall of both how long somebody can stay in and how severe their symptoms get, because the longer they can tolerate virtual reality, it opens up more options for us on the treatment end of things. So for my study, I am looking at 20 to 30 patients that are being recruited through the Central Arkansas VA GREC. So for my study procedures, I am collecting demographic information before the study. I'm also taking baseline measures of gait and postural stability using a actual Wii Fit board to assess their balance. Then I'm looking at their galvanic skin response, heart rate, blood pressure through a fancy wristwatch that collects that data for me. I'm collecting that at baseline, and then I'm tracking that throughout the study as well. And then before they complete or actually start the virtual reality experience themselves, I'm having them complete a baseline measure of the simulation sickness questionnaire, which, as I said, in older adults is really important because a lot of them come in reporting a baseline level of cyber sickness, a lot of times due to nausea or disorientation or things that accompany some other physical problems that they're dealing with, or some of the medication side effects as well. So I want to get a baseline measure of that. And then after I get all of that baseline data collected, I have every participant engage in a 20 to 30 minute virtual reality session, which includes just playing virtual reality mini golf for 20 to 30 minutes a piece, or until they need to be pulled out of the experience due to severe symptoms emerging. So far, that's yet to happen, but I do have that as a caveat because a lot of my participants in my study are 65, 70 plus, including a few 90-year-olds. And my biggest concern for them is keeping them safe. So the last thing I want them to do is get very unwell or increased risk of falling. So once they indicate they feel unwell, we stop the study then. But the reason this golf game was chosen was because of its simplicity, frankly, and enjoyment. It's pretty easy to use. It only requires use of 2 buttons and ability to kind of spin around. So for those that can't stand up and walk around themselves, I've had patients successfully do this in a rolling office chair, and they've been able to engage just fine. And that also kind of promotes their safety, as well as expands the people that I can use this with. And then finally, after that is done, I take the post-assessment measures, including re-administering the SSQ, gathering the physiological data, including post-test balance and sway data, and then I have them complete questionnaires based to examine what their experience was like, whether they enjoyed it, what they enjoyed, what they didn't enjoy, and what they would change, both via self-report measure and open-ended questions. And then after patients complete their initial session, they are booked back for 2 to 4 additional assessments to using the same study procedures to track changes across time. So to date, I've had 4 patients complete this study so far. And so I do have limited data, but a lot of the qualitative information that I have noticed is that the patients have reported initial hesitancy. They're pretty wary of what's happening to begin their experience, but once they get into the virtual reality experience itself, a lot of them are reporting really enjoying what they are doing. So much so that I've had several, actually, I think every patient that I've had so far has asked, where can I buy one of these? How can I get one? Or can I come back and do this again? They've really enjoyed it. Kind of related to that, all have reported minimal experiences, and the range of ages I've seen are 70 to 92. So it's been, even amongst the 4 patients, there's been a pretty big range of ages that I've seen, and all of them have reported minimal physical and cognitive side effects after the experience. So notably on the biodata that I am collecting, I have noticed increased heart rate and galvanic skin response throughout the engagement in virtual reality. Importantly, as they are engaging in this study, I continually ask how they're feeling just to check in on them. They're not reporting anything adverse side effects wise, but this is just something to kind of keep an eye on and note if it continues to be a trend after all the data have been collected. And then some qualitatively, some salient feedback and critiques include, there are some initial difficulties understanding the game control, and this is not surprising given that majority of patients referred to me have MCI or major neurocognitive disorder. So the biggest thing is repeating the instructions and keeping things consistent. I've also found that a modeling approach helps by showing them what to do and having them watch me and then explain to me the process of what I ask them to do. That a lot of times helps that sink in. Having an overly constrictive play area, this may be just a site-specific problem. VAs are usually a little bit cramped for space, and this one's no exception. So having a wide open space that's free of obstruction is needed, but sometimes a luxury, but that has been a salient critique. And then finally, there have been some concerns about the weight of the headset and slight discomfort with the glasses. And that's just one of those things that it may be different headset to headset, but it's difficult to control for because they are heavy. There's a lot of tech that goes into them. So that is it. I would like to thank Dr. Padala, Dr. Mooney, and Dr. Preston, who helped me on my study, as well as Kevis and the GREC for providing facilities for everything.
Thank you so much, Dr. Moore. Folks can feel free to put their questions in the chat box, but we'll get to the questions in the question and answer box, but we'll get to all of your questions at the end of all 4 talks. Let's move on to a second speaker, Dr. Amie Preston. She's a staff neuropsychologist at the Central Arkansas VA healthcare system and is doing work in collaboration with the University of Arkansas for Medical Sciences. Dr. Preston will be speaking today about the feasibility of using immersive VR in older adults with cognitive impairment. this is arguably the most complex patient population to consider the use of VR for. So we're eager to hear what you have to say, Dr. Preston. You have the floor.
Thank you, Dr. Vahia. Yes, I'm very excited to present what we found so far. And so what I'll be discussing is the study that I'm currently funded for here at the VA, talk about some of the successes, some of the barriers that we've experienced, and really just talk about the study as a whole. There we go. So to give a little background of the study, it is a 2-year funded study where we're looking at the acceptability, feasibility, and perception of technology, which was part of what Dr. Moore was just speaking about, with an older adult veteran population. So with this population, we are targeting veterans that have apathy associated with their cognitive impairment. And we also ask that they have their caregivers come along and their caregivers provide additional information about any neuropsychiatric symptoms related to their cognitive impairment. Now, we don't limit it to those with mild cognitive impairment. We see veterans on the spectrum of mild cognitive impairment all the way up to major neurocognitive disorder or dementia. The length of their participation in the study is just a one-time study visit. And so they're not required at this stage for this study to come back for multiple visits. We are proposing and hoping to recruit 30 veterans and 30 caregivers by the completion of this study. Again, it is that one-time study visit where the veterans complete pre and post assessments, and then the veterans also engage in the intervention and use of the virtual reality device. So the maximum time that they are able to use the device is 30 minutes, going back to the research that Dr. Moore was just speaking to, of that really being the end of the mark, or the end of the time period that you really want individuals engaging and using the virtual reality device before you can start to see some of those cyber sickness symptoms he was speaking to. Now, the veterans, of course, are able to end the experience before the 30-minute mark. And just as Dr. Moore, I consistently check in, see how they're doing, see how they're feeling during the different experiences that they have. They are also wearing the wrist wearable device that tracks heart rate, galvanic skin response, and peripheral temperature. And so for our study, we're using the Empatica E4 device to track all of these different measures. So the device that we are using for our study is the HTC Vive Pro I. A couple of features that we really like about this device is the built-in audio. So there isn't a separate headset that we have to do. We don't have to rely on external speakers, but it is the audio system, headset system, that is already built into the device. The headset is adjustable. We're able to fit it to the veteran's comfort level when they're engaging in the experience. And one of the downsides to using the HTC Vive is that it does have to be connected to some type of either desktop or a laptop while you're engaging in the use of it. So with this, you can either use the tethered approach, where the HTC Vive is physically tethered into the desktop or the laptop, or you have the option to use the wireless approach, but it still has to be within range of that desktop. There are also external base stations that are used to create the play area. And one of our other panelists, Dr. Harmehr, is going to speak about some of those differences in being able to make the play area boundaries with the Oculus versus the HTC Vive. And so with the Vive, it is an external device that marks the play area where the individual engages in the virtual reality experience. The Vive has eye tracking capabilities, and one of the most important reasons that we went with this device is that the website where we as government employees have to purchase our equipment, this was the virtual reality headset that was able to be sold at the time that we were looking to purchase our equipment. So this is the one that we went with. I wanted to highlight some of the virtual reality options that some of the veterans have, and some of the more popular ones that they've chosen during our research experiment. So NatureTreks VR, and I don't know if individuals are familiar with this one, but veterans have an option of more than 10, a little more than 10 environmental scenes that they're able to engage with. So here you can see a mix of some of the different scenes that are options for them. You see the luminescent forest, the meadow in the center with the deer grazing in the meadow. You see a beach at sunset, and then an underwater scene. And throughout these. So you're able to hear birds, you're able to hear this relaxing music that's also played. And the veterans are able to navigate or walk through the experience to see different animals, to engage with the environment. And I'll talk a little bit more about how they respond to these different apps and environments as they're engaging in them. Excuse me. So the option to the right is Journey Through History. So with this, the veterans have an option of 4 different locations where they are able to navigate and learn about the different locations. So this one in particular is the ancient capital of Thailand. And if you can see the yellow beams that are highlighted in the back, those lead to different artifacts or different sculptures, different types of information where the veteran is able to click on it and gain more information about the culture, and also gain more information about maybe the architectural history of it and just the historical significance of that area and how it continues to play a role in present day. Veterans that, and so with our study, we do an interest checklist to see what some of the interests are that our veterans have to be able to better choose an experience that they may enjoy. And these have been the 2 most popular ones that our veterans really highlighted that they wanted to engage in, and they have genuinely enjoyed being able to engage in both of these options. Now getting into more of the study demographics and the nitty-gritty of the study. You can see here, I won't go line by line with each of them, but some of the demographic differences between the veterans that we've had and the caregivers. And so while we're proposing to have 30 veterans and 30 caregivers, so far to date, we've had 13 veterans and 10 caregivers be able to participate in the study. And so keeping that in mind when we're looking at some of the demographic and even some of the averages of some of the assessments here in just a little bit. We can see average age around 70, 67 for veterans and then caregivers respectively. We are looking to partner with more community programs outside of still veterans, but more community programs outside of the VA to really get at underrepresented populations, because that is one of the other hopes of this study, is to not only look at the feasibility of using immersive virtual reality with veterans who have apathy associated with cognitive impairment, but also really get at how is it viewed? Is it feasible? Is it tolerable? Is it accepted by underrepresented populations who still present with apathy associated with their cognitive impairment? And so right now, still a little bit more white individuals than Black individuals being able to participate in the study, but we are working on making those numbers, evening them out a little bit more. Occupational status, a lot of our veterans are retired, excuse me, not a lot, all of our veterans are retired and loving it. And so they don't have the added strain of having to get off of work, schedule around work to come in for the visits. And educational history, you can see a difference in the veterans and the caregivers that have presented. So most of our veterans so far, either high school diploma or some college, whereas our caregivers run the gamut of high school diploma, some college, master's degree, and also doctoral degrees. Now I'll look at the specific aims. So 2 of the specific aims that we have for this study. The first one, to examine the acceptability of IVR use in veterans with apathy associated with cognitive impairment. So what we have seen so far to date is, although not statistically significant with the 13 veterans that we've had so far, clinically significant findings in the perception of technology. And so this does go back to what Dr. Moore was speaking to. What we have seen is that we do a pre-assessment and post-assessment about perception of technology, what the veteran thinks about virtual reality, how you feel about virtual reality, and the scores do improve after they engage in the experience. So you can see some of the nervousness, some of the, I don't really know about that before we engage in it. Though all of the veterans have been very accepting of it, have been willing to at least try out the technology, try out the headset, get into the experience and really give it a chance. And I do keep that in mind. We do a slower introduction in introducing the headset once we're done with the pre-assessments, and we really do step by step of, this is the headset that we've been talking about. You know, this is the part where I'm going to put this onto your face. Is it okay if I do that now? And then walk them step by step as we're doing the process, showing them the controllers before I put on the headset. I had to learn that one the first time. And telling them, okay, these are the trigger buttons that I'm going to reference when you're using the headset. And I may say, press your right trigger button for something, or press your left trigger button. And so really taking into account all of the differences that this population, this generation has seen with technology, and taking that step-by-step approach, even thinking about the differences that they've seen with telephones, going to cell phones, with regular watches, going to smart watches. And this is just another one of those technological advances. And so really going at the pace that's comfortable for them so that they feel more comfortable engaging in the experience. One of the best parts to me, one of the parts that makes me smile the most sometimes, is when the veterans engage in the experience and just the reminiscence factor that they have. And a lot of it is with the Nature Treks application. So a lot of veterans will choose a scene that reminds them of maybe where they grew up, or they'll choose a scene that reminds them of something in their lifetime, in their environment, in their current atmosphere, their current environment, or something from the past. But just having them engage in that experience and then tell those stories as they're walking through the Nature Trek scene has been very rewarding for them, but also rewarding for myself and my team to be in that experience with them. And I think it also speaks to Arkansas in general, just being the natural state. There's a lot of outdoor activities. This is a place where you want to go hiking, fishing, you want to go kayaking, you want to go camping. You can do it all pretty much here in Arkansas with those outdoor activities. And so the veterans have likely engaged in those activities throughout their lifetime, and they're able to reminisce on that through the Nature Treks experience. So with our second aim, we're looking at the feasibility of using the device with this same population. So with the simulation sickness questionnaire that Dr. Moore was speaking to, out of a possible 48 that can be scored on it, with our 13 veterans, they're averaging a 1.62 on it. So showing that they're not really experiencing a ton of the simulation sickness symptoms. Some of the ones that have been noted more frequently is, one of them is difficulty focusing. Part of that is with the technology sometimes. So with the wireless option, some days the Wi-Fi isn't working the best, and so the picture is a little bit grainy. And so veterans are able to comment on that and mark that on the simulation sickness questionnaire, because although it's not their eyesight, it's the image that's within the headset that could still cause other simulation sickness symptoms. So we do want to mark that and reflect it on the SSQ. With the Slater-Uso-Steed presence questionnaire, this was a questionnaire that I ran across to really get at the immersiveness of the experience. So how are they experiencing it? Do they really feel that they are there? And that's what the questions get at. So some of the questions could be, did this place remind you more of a place that you visited or the images that you saw? Did you really feel that you were present in this experience or in this environment? And so here we see, out of a possible 42, a 31.1. So for the majority of veterans, they really feel immersed, or really feel like they were present actually in that environment, walking through that experience. And one of our other assessments is the physical activity enjoyment scale. So out of a possible 126, right now our veterans are averaging a 102 on that, showing that they are genuinely enjoying the experience. They do feel immersed in the experience and not really experiencing a lot of simulation sickness or cyber sickness associated with it. And so going forward, one of the areas that I really want to make sure to look at is, especially with the population. So again, thinking about, we're working with veterans with apathy associated with cognitive impairment. And so is this a type of device? Is this something where even those with apathy can feel more immersed in this experience, and can it lead to a reduction in apathy or apathetic symptoms? Can this be something to be used to enhance positive quality of life, to enhance mood, whereas maybe some other skills or techniques may not meet the mark, like immersive virtual reality can? Can this be another option to use for this population? All right, so some of the barriers that we've found, some of the challenges that we've had to work through in the study. The queuing for the controllers is not so much a barrier, but just one of the little bit of a challenge that we've had. again, thinking about the population that we're working with, these are individuals that do have cognitive impairment. And so throughout the experience, I do have to continue to remind them about the cueing of, oh, okay, this is what the right trigger button does, and this is what the left trigger button does. And the only reason I really wanted to highlight this is for me to keep in mind in future studies also of, is there another type of option where there isn't as much required on their end for the cueing? Now with that, I did for one individual see if, oh, okay, if I did the controlling, maybe that would ease the frustration of having me constantly remind them, but they would still enjoy the experience. And it seemed like it took them out of the experience more. So the veteran wasn't as immersed in the experience, and possibly because he wasn't doing the controlling himself. So for the other ones, we just continue to do the cueing, and there are veterans that pick it up fairly quickly, but then for others, we do have to do that cueing throughout the experience. As I was speaking to, network connection sometimes isn't always as reliable, which can lead to a little bit of a grainy image. Sometimes for the majority of individuals, we haven't had an issue with it, but when it is an issue, it's an issue and it sucks. The base stations that I was speaking to are required. So this isn't a device where you can just pick up the headset and the controllers, take it into a different room and use it where you have a little bit more space or a little bit more room. You have to make sure there's a desktop in there. You have to unplug the base stations and plug them into the next room so you can create the play area for the virtual experience. And then also the volume. While I love that it has the attached headphones to it, for some of our individuals that do already have hearing loss and have hearing problems, even as loud as that volume goes, is still not loud enough for some of our veterans. So that is one of the other pieces that has been a little bit challenging for us to work with. All right, so really quick to wrap it all up. Right now, what we are seeing is that with the veterans that we have, it is generally accepted by them. They're giving it a chance. They're getting in there, trying it out. It's feasible with them. They aren't really experiencing a lot of the simulation sickness symptoms, and they do feel like they are immersed in that experience. They are immersing themselves in it and really feel as though they are present there in the experience. We're still continuing to explore the galvanic skin response, the heart rate, and how all of that connects, because just as Dr. Moore was speaking to, we are seeing that once the stress response and once the heart rate goes up during the intervention, they don't generally come back down until after a little ways, but we make for sure that people are back at their baseline before we just cut them loose at the end of the study. So I do want to highlight my mentors, Drs. Prasad Padala, Kalpana Padala, Scott Mooney, my wonderful team members, Mr. Chris Parks, Ms. Lacey McGee, the Central Arkansas Veterans Healthcare System, and within that, the Geriatric Research Education and Clinical Center, and funding for the project, the VA Office of Research and Development, and also Johns Hopkins Alzheimer's Disease Resource Center for Minority Aging Research, and then also Dr. Moore for his technological expertise when we have some of the issues with the headset. Thank you.
Thank you, Dr. Preston. Wonderful talk and just wonderful work, breaking new ground at so many levels. We have some questions coming in. Please feel free to add your questions. And as I said before, we'll answer them after all 4 speakers have wrapped up. Our next speaker is Dr. Anna Trueba. Dr. Trueba is a staff psychologist at McLean Hospital and an instructor in psychiatry at Harvard Medical School. I have the pleasure of working closely with her, and she will be presenting some of the early work that she is doing around affordable virtual reality, both at McLean, but also a project that she is doing in collaboration with the Universidad San Francisco de Quito in Ecuador, where she continues to hold an adjunct faculty position. Dr. Trueba.
Thank you so much, and good morning to everyone. So today I'm going to be talking a little bit about using affordable virtual reality headsets and how that can open up the use of virtual reality in different settings. So this is a little different, I guess, than what we've seen in the other presentations. The headsets that we're using are a lot more affordable. And so this gave us the opportunity to really look at how this can disseminate and maybe make it more acceptable and easier for folks to use at home in clinical settings and increase that flexibility. So we did 2 studies. That's why there's 2 separate aims. One study was done at McLean Hospital, and we implemented a mindfulness intervention using the VR headset that I'll show in a bit in our geriatric psychiatry inpatient unit. So very high acuity patient population there, a lot of different diagnoses. And then the other study was done in Quito, Ecuador, with the collaboration of Universidad San Francisco de Quito. And there we did also another mindfulness intervention in a geriatric population, but these were outpatient patients. So different clinical setting and also wildly different cultural context. And again, this was to see if, the fact that we're using low-cost VR could really lend itself for this flexibility. So this is what the low-cost VR looks like. This is the headset. It goes for about $40 or so on Amazon. So very low cost. And what makes it low cost is that we rely, and I'll show you in a bit, on a virtual reality app that you can download on your phone. So the phone is doing the virtual reality, so to speak. And you just place your phone, having activated the app and the scene that you want to see, and then you just put it into the headset. So this allows it to be quite affordable. When setting up, one of the obstacles that we encountered, that it was really difficult to find compatible virtual reality videos that were 360 and were also suitable for our DeskTech VR headset. It was also challenging to standardize the quality and content of the video. We found that the majority of available content was more recreational and had a lot going on because it was supposed to be more for fun and wasn't very suitable for mindfulness. Because again, as other presenters have already alluded to, to get into this mindful state, you really don't want things jumping at you at the screen. And then it also required the use of a smartphone, like I just talked about, and this could also bring up privacy issues, especially if we're using patients' own cell phones. And then if you use platforms like YouTube, you have the potential for commercial interruptions, etc. So how we solve this is using this Sites for VR app. It's a static VR, and it has a variety of different scenes to choose from. We did the nature scenes because our mindfulness intervention was very much focused on sort of imagining taking this mindful walk through nature. And I think what the patients enjoyed the most is water scenes, waterfalls, or oceans, rivers, that they could look at from the beach or from a boardwalk. And so those were some of the more popular ones. And then to resolve the privacy issue, what we did was we gave patients cell phones that were purchased for the study in both settings, both in McLean and also at Ecuador. So that really helped mitigate those obstacles. And then lastly, we did not do a recording of any kind in terms of like narrating or embedding sound into the videos, but rather we came up with a script that clinicians just read out. It's a standardized script. And this helped also not having to have so much difficulties embedding sound into the app. It also allowed for flexibility, especially on the inpatient unit where patients' functioning is pretty low. So that, if we're running the audio, we can interrupt, we can help patients, etc. So when we started implementing, some of the obstacles that we encountered was that some of the older adults really expressed a lot of anxiety about handling technology. And so we had to sort of reassure them, and Ian also spoke a little bit about this. We also did sessions where we just allowed patients to try it on. And try to encourage them to understand that they don't really need to do anything. They can't mess it up or do anything wrong. It's more an experience than a performance. And so we really tried to emphasize that, and that helps. We also did find that this app is fantastic, but at times, for some reason, it tilts the image. And so that would require restarting the phone. I tried different things and I really couldn't get it to work unless I restarted the phone. So what I did was I had a cell phone on, right beside it that was running the app at the same time with the same scene, and just troubleshooted by replacing the cell phone quickly so as to not interrupt the intervention too much. Patients, especially on the inpatient unit, were reluctant to participate if we asked them to fill out too many forms. So we had to reduce the amount of paperwork, which also meant that we collected less measures. But I think that worked out for the best. The feedback we got from patients is that VR mindfulness interventions really facilitated powerful therapeutic processes like reminiscence. A lot of patients also described feeling more connected to the moment, emotional acceptance and awareness. We had a couple patients that described having ADHD and attention issues, and they really described that the VR helped them be more in the moment and facilitating that mindfulness intervention. For the Spanish intervention, and for both interventions, really, we've already reached 75% of our recruitment goal. But some of the main difficulties that we encountered there was the scarcity of virtual reality videos that were compatible with our headset and were also in Spanish. So again, we used the mindfulness script that we used at McLean in English, translated into Spanish, and that seemed to work really well. And so again, you know, the fact that we didn't try to embed audio into our VR helped and kept things flexible. And we were able to do that. We also translated, obviously, all our measures into Spanish. Another thing that we found difficult is that the first cell phones that were purchased did not have a gyroscope, even though Samsung had told us that it would be fine. And we found that that was not compatible with the VR headset. Here in the US, the use of iPhone is very widespread. In Latin America, Android is more popular. And so there's less options. The iPhone is very expensive. And so finding options that are, you know, affordable, but that are also compatible with VR was a little bit of an obstacle. Still very inexpensive VR on the whole, but, you know, trying to find that phone was a little bit difficult. And so I just wanted to present really quickly a patient vignette that sort of highlights some of the feedback that we got and what the intervention was like for some folks. So this was a 78-year-old male that was diagnosed with dementia and was hospitalized at our geriatric inpatient psychiatric unit to treat some of his behavioral issues. He did not have any agitation, sort of aggressive symptoms, but did have a little bit of agitation. But he was able to tolerate group therapy, and he was receiving supportive group psychotherapy at the inpatient unit and also medication. He agreed to participate in our study, and he received three-day mindfulness intervention. In the first session, he saw a nature scene that included water, and he really liked that. And so he requested that the second session also be with water. So we did a scene where he was standing on a boardwalk looking out into a body of water, and the patient started describing how this experience was reminding him of when he was younger, and how it brought up a lot of these memories of connecting with friends, fishing, and we reflected on that process, some of those emotions. And so this is a good example of how the VR seemed to facilitate that reminiscence and help with emotional acceptance and being in the moment. He also, as Ian suggested, was one of those patients that wanted to know where he could purchase the headset. A lot of our patients enjoyed the intervention so much that they asked us for the Amazon link to the headset and what the app we used. And again, I think one of the advantages of the affordable VR that we use is that patients could do that. If they already have a cell phone, the cost of the app and the headset is pretty affordable. So that's one of the advantages. So the conclusions of our mindfulness interventions using virtual reality is that, you know, affordable headsets might be a great way to address stress and mood symptoms in older adults. However, there are many details that one must take into account when implementing these interventions. As I just described, you know, we had a couple of obstacles. And we see this as the first step of establishing sort of best practices for low-cost VR across, you know, different settings and countries in older adults. And I'd like to thank McLean and our lab for, you know, supporting this work.
Thank you, Dr. Trueba. We're starting to see a lot of really good questions come in, and I know that a couple of those questions have been answered already. Please keep putting your questions in the QA box, and our presenters will answer some of them, but we'll also discuss them going forward. Our last speaker for the panel is Dr. Harmehr Sekhon. Dr. Sekhon is a postdoctoral research fellow at the Technology and Aging Lab at McLean Hospital. And she also has a joint postdoctoral appointment at McGill University and the Jewish General Hospital in Montreal, Canada. And in a sign of what the pandemic has made possible, she's been working on this collaborative postdoc all while being based in Toronto. Sort of welcome to academic life in 2022, I suppose. Dr. Sekhon will be speaking about her own work with VR in older adults at the Jewish General Hospital in Montreal, and discussing some of the early lessons from the work that they've done in the field. Dr. Sekhon.
Thank you very much, Dr. Vahia, for that wonderful introduction. I'm really excited to be sharing with you all our pilot randomized control trial of a mindfulness meditation virtual reality program. So just going to make sure it's letting me click next. Sorry, technical difficulties here. Okay, there we go. I think I'm able to now. Okay, wonderful. So just before I get into more about our intervention and how we went about creating it, I'm just going to give you a brief overview of the study and essentially what our objectives were. So for this pilot randomized control trial taking place over 4 weeks, our first objective was really to assess the feasibility and tolerability of virtual reality with older adults. And we're using the Simulator Sickness Questionnaire for this. Our second objective was to assess this virtual reality mindfulness meditation program's effects on stress, anxiety, depression, as well as other outcomes, including mental health, sleep, quality of life. So a little bit more about the intervention itself. When we started to really want to create this intervention, we were hoping to use pre-existing virtual reality content or an application that was pre-existing. But unfortunately, what we found was that there's really a lack of content right now that's available for mindfulness meditation in the VR sphere. And what is available is either very low quality audio or visual wise, or if it's something on YouTube, it'll have interruptions in the form of ads. And so that really led us to want to create our own virtual reality content. And of course, we did this without any prior experience with VR. So quite a bit of learning is what essentially went down for us just to be able to create this intervention. So we created a total of 8 different videos. All videos were 15 minutes in length, and they were all stationary or static virtual reality videos. Essentially, we wanted to be very mindful of the fact that older adults in this intervention were probably using virtual reality for the first time. And these were older adults that we wanted to just ease them into VR, and we wanted to reduce the likelihood of motion sickness or other possible negative outcomes of virtual reality, as Ian had talked about earlier on. And so for each of these sessions, we recorded a video in a different environment. So actually the 4 images that you see are 4 sample settings that our videos were recorded in. We recorded the audio in the settings as well. In addition to that, we audio recorded a 15-minute guided mindfulness meditation session. And all of our sessions really were focused on breath work and body scans. And essentially, when we were creating these sessions, what we were wanting as our goal was to be able to, for these older adults, for most of which it was even their first time being involved with mindfulness and practicing mindfulness meditation, we wanted a session where they could begin with more guidance. So more talking from the actual, the audio, from the person guiding them through the mindfulness meditation. And then as the sessions went on, we had less and less instruction. So we really wanted them to be able to practice more of what they had learned, so they were able to continue this even after the intervention. Another component of this, just making sure we were leaving these older adults with these tools and with the content that we had created, was that we made all our videos freely available on YouTube without any ads. And all the older adults were given the links for these videos, and they're freely accessible to everyone. For our sessions themselves, what we did was we were able to download them onto the Oculus Quest 2. And I'll tell you some of the reasons behind that. Primarily, it really was due to the fact that the study was designed just prior to COVID. But as we were, this was taking place during the pandemic, we really wanted to be able to give participants the option of doing this in home or in person. And I know you probably have a lot of questions about how is it possible that we can give, a virtual reality device to an older adult that's never used this before and expect them to be able to use this in an in-home setting. And we were actually able to do that quite successfully, and I'm excited to share that with you. But in order to do that, what we did was we downloaded all of the videos onto the device so they wouldn't have to use Wi-Fi. So there was no concern with lagging or video quality due to poor Wi-Fi connectivity. All the videos were shot using GoPro, and I'm always happy to connect offline with anyone interested in learning more. Our interventions took place both in English and French, since we are based out of Montreal, Quebec, Canada. And participants, before they were randomized to the waitlist or the intervention group, were able to select whether they preferred to do the intervention in person or in home. If they were doing it in person, we took COVID precautions, so sanitizing the device using a UV device, wiping down surfaces, and so forth. And so I'll give you a little bit of an overview on the participants. So we consented a total of 25 participants for our study. After we consented them, 3 dropped out before we were able to randomize them. So with the remaining 22, we gave them the choice between the in-home or the in-person modality. Approximately 12 chose the in-home delivery method of this program, and 10 chose the in-person. And then those individuals were randomized to either the VR meditation program or a waitlist control group. So we had 6 in each for the in-home delivery and 5 in each for the in-person delivery. We were able to complete our baseline assessment for all 22 and completed our follow-up assessments for 20 participants. We just finished data collection, and we're actually just in the process of completing our qualitative semi-structured interviews with some participants. So we're excited to share data in the coming weeks or months with you. So I'm just going to give you a quick overview because throughout our presentations today with my 3 wonderful co-presenters, we've talked about different VR devices. And I just thought this would be helpful to kind of have an overview if you're interested in using VR and you might be wondering, why did we use the specific VR devices that we've selected? What are the costs? What are some of the abilities and pros and cons? So starting out with the desk tech, which Anna used at McLean, it's a lower, more accessible a virtual reality device that costs about $75. The wonderful thing with this device is that you're actually able to use your cell phone right into it. So it's very accessible in a variety of different settings. One thing that might be a con for this device is that we're not able to actually project what's being seen by the participant onto a screen. And also there's no built-in speaker outside of whatever the phone is able to provide. What our team used in Montreal was the Oculus, the Meta Quest 2. So this is a device that provides you with a 360 video and the audio built in. We're also able to see what the participant is seeing on our screen. What led us to actually use this device is that it wasn't too costly. Of course, it's still quite costly at around $400 US, but also the fact that it had a safety feature built in, whereby for all of our interventions, we asked participants to remain seated in a chair just to minimize any risks of falls. And what you're able to do right into the Oculus is set a boundary. And what the boundary means is if you're choosing to, let's say, partake in something where you're going to be moving, you can set a boundary around your room. If you're choosing to partake in something that's stationary, you can actually set a stationary boundary. And any time that you get close to this boundary that you're setting, you'll actually be able to now see the room instead of what's being shown for the VR content. So that was a safety feature that we quite appreciated, and that's why we went with the Meta Oculus Quest 2. Similarly, the HTC Vive, which the earlier 2 presenters used, also has its safety features. It's a little bit more advanced. It's also able to track the full body of the participant. And some of the cons for both the Oculus and the HTC Vive, and I'll share more about it in our participant feedback, is that they are quite heavy in terms of the headset, and using them with glasses can be not as comfortable. And so that was noted by our participants as well. So just some quick preliminary data to share. Our participants, the criteria was older adults above the age of 60, but the mean age that we had was about 73. And we had about 90% participants that were community dwelling. About close to 10% were from long-term care. We didn't have an inclusion criteria specific to which setting. We really opened it up to any older adult in Montreal. And about 86% were women. What was really interesting for us was that within both the in-home as well as the in-person groups, participants were really able to complete the intervention with very few technical difficulties. And this is really important because, especially for the in-home group, outside of our first digital literacy seminar, which was done by Zoom, they were doing this completely on their own. There was no inclusion criteria of having to have a caregiver at home. And for many participants, they didn't have a caregiver at home. So it's a real success to be able to know that older adults who have never used virtual reality before are able to use it successfully on their own with support via Zoom in an in-home setting. So we had 3 minor technical issues. And when we say minor technical issues, these are issues that were resolvable within the same session. And we had no major technical issues. These would be issues that resulted in the session not being able to be completed. So that was very promising for us. And some early qualitative feedback that we've received through our semi-structured interviews. In terms of digital literacy, we did note that participants had a fear of unknown. So some of them came into the intervention not really being sure of what to expect and thinking virtual reality is something more for younger individuals. That's what some of them shared with us. There was also some technical issues that were noted, but again, this is usually in the first 1 or 2 sessions and then resolved. There was one participant who had some difficulty because of her glasses and wasn't really able to get comfortable enough with the virtual reality device due to the glasses. So that was very important feedback. In terms of the videos, they would love more green sceneries, and because we shot the videos in wintertime in Canada, which was very snowy and cold. So we completely understand, and that's something we'd love to incorporate. And they really did note that they love the water and the sounds of the nature itself, which we did keep in our videos, which was really nice feedback. And so overall, they found the sessions to be really nice. They felt light and better, and they were really open to using VR again. And I'll just maybe speed up a little bit here to allow time for questions. So some barriers for older adults that we noted. So virtual reality may not be suitable for older adults with cognitive, visual, or hearing impairments. Digital literacy was something that we thought was something very important to consider when creating a virtual reality intervention. It has to be something that we think about and incorporate right from the get-go. And I think that's what led to the success, especially of the in-home setting of our study. And then in terms of access to technology, the large costs associated with VR is something that we do have to think about actively, because for many of these older adults, they'd love to continue using the technology, and we'd love to maybe find a way to subsidize it for them. So just a few other quick notes. We were really fortunate to be able to bring in older adults earlier on as we were creating the intervention. I think that's really important and missing for the kind of the wide VR content available right now. I don't think much of it is very specific to older adults or geared towards them, and that's really unfortunate and could be improved upon. We touched upon digital literacy briefly. That's really something wonderful. We even gave them handouts with images of, this is what the power button is going to look like. This is what your home screen is going to look like. And that was really helpful. They really enjoyed that. Recruitment was wonderful. We really, we got older adults that were very, very enthusiastic. In fact, calling us and just being like, when is the study starting? So that was wonderful to see. We really enjoyed that, and it made the study all the better. So that was wonderful. And then accessibility, we're really excited about the fact that we going forward, we can plan more in-home accessible studies around VR. And that was a huge plus for us, and we're really excited about that. So I think with that, maybe I'll just skip over this slide so we have some time for questions, and I'll just say thank you.
Thank you for that wonderful talk. And just a quick note of acknowledgement to all of our panelists today for your presentations and really for the groundbreaking work you're doing. I think it's important to emphasize to our audience today, both watching live and those watching this on recording, that this really represents some of the earliest evidence to support the use of virtual reality in older adults. And this is the work that's sort of forming the earliest parts of what will hopefully become best practice guidelines around how to use VR in aging. We have several questions lined up, and I know some of them have been answered already. I'm going to break order though, and revive a question that Dr. Preston has answered already, because I think this is really important. A common thread throughout our panel has been the issue of making VR affordable, accessible, and easy to use. Dr. Preston, you answered this, but I'd like to give everyone an opportunity to chime in. In your experience, how have you found that different racial groups or veterans from different backgrounds or cultures have used VR differently? And I think we can expand on that to sort of get into what factors should someone looking to use virtual reality, whether for a research project or in clinical practice, how should this be approached? And if you can share either perspectives or tips on be more comfortable. Dr. Preston, we'll start off with you, and then have Drs. Trueba, Sekhon, and Dr. Moore chime in.
Yes, thank you. And it was a really wonderful question, and one that in the response, me putting that I'm not oblivious to the fact that myself being a Black psychologist here possibly plays some part in veterans wanting to accept or not wanting to do the research study. And it is something that I don't take lightly. I do understand my role in my position and how I may be viewed by some of the veterans that may be engaging with this. And so it is something that I'm very considerate and thoughtful about when presenting to these individuals, really taking time to hear what maybe some of the ambivalence may be about, maybe what some of the hesitation is, really hearing them as a person, seeing if there are any barriers that we can address, and then taking that step by step, as I was saying, of, taking it slowly. This is what we're going to do. This is how we're going to do it. I'm going to place this over your eyes. Let me know if this is too uncomfortable for you, and really taking it at a slower pace. Because as I was saying, even in thinking about the technological advances that this generation has seen, even more so for racially underrepresented populations, it can be seen a little slower, because while other people were getting radios in homes and TVs in homes, that probably wasn't something that was coming from racially underrepresented populations until later. Getting cell phones when the rest of the world was getting them wasn't something that happened at the same time for some of these populations. So really appreciating and understanding that they may feel a little bit further behind the curve because racially underrepresented individuals, due to affordability and accessibility issues, may not get what the rest of the world gets at the same time. So having some of these affordable options, as some of our other panelists have spoken about, and really fitting it to the needs of that population is highly important. And I'll let some of our other panelists answer.
Dr. Trueba and Sekhon, if you could also sort of speak to the fact that you adapted this work for, in your case, on a low and middle income country scenarios, with Ecuador being the example, but also adapting it to Spanish, and Harmehr, in your case, adapting it to French.
Yeah, so I think it is a very interesting, this is a new field, and even newer for, different countries, different cultures. Even here in the US, it's pretty new. So it's been very interesting to navigate that territory. I think, the low cost VR that we use does lend itself well for this, because I think the main barrier for countries like the one I'm from, which is a low middle income country, is the cost. People upfront, most clinics, they don't want to invest in mental health. And so the fact that it's low cost does reduce the barrier to using virtual reality. Because since it's such a new technology, there is that initial distrust. Well, why would we invest in this? Would it be helpful? But the fact that it's low cost does, I think, reduce that obstacle, makes it more likely that they might take the risk and, implement it. But like I suggested too, the fact that it is a low middle income country, iPhones are too expensive for most folks. And so we might encounter that some Android phones just don't have a gyroscope. So even if we're using low cost VR that relies on a phone, that could be another obstacle that we encounter.
Dr. Sekhon?
Yeah, I'm happy to add to that. I think for us, really, we were very mindful of that, and that's why we first of all wanted to ensure that our videos were downloaded onto the devices in case Wi-Fi was a concern. Secondly, we were really fortunate actually in our previous research studies to have worked with a wide variety of community programs and stakeholders. So we've been, because of our previous studies during COVID, we've been in touch with over 20 to 30 community organizations. And that's been a huge plus for us because we've been able to recruit more diversely by incorporating them actively from day one. And being able to really get this, get information about the study out to groups that would otherwise be more hesitant or, might not be included in the same numbers. So that was our approach to this.
Dr. Moore?
Yeah, so I think the biggest thing that I have found is there hasn't been, at least as far as the few people I've seen, a huge reluctance for racial minorities to participate. The biggest thing is up front when I'm calling them about their willingness to participate or not. I'm very careful to explain in pretty good detail what I'm going to have people do, especially with mine. Looking at tolerance, I'm specifically looking at whether it's going to make people feel unwell, and I feel that they should know what they're signing up for explicitly before they get there, especially with minorities and their views of healthcare being adverse at best in some cases because it hasn't exactly been geared towards them or treated them well historically. Making sure that they know, like, this is my intention of doing this study. It's for potentially future improving the field. And so if you do feel unwell, that's part of it, yet it's not we're not aiming to do that. We're aiming to help improve everything and kind of giving them all that information up front to help them make an educated decision on whether they want to even participate at the beginning. And then, of course, as with all research, making very explicit, you can do as much or as little as you feel like doing. You can withdraw anytime, and this is purely in your control. And, I want to do this for your enjoyment as much as anything. So.
Thank you for those responses. I think the points all of you make, and they're in sync with some of the points made in yesterday's sessions, including the keynote and the industry panel, that it's really not about the tech at all. It's about picking tech that's going to be usable by the largest possible amount of our population. Now, this includes minoritized populations, but minoritized in a number of different ways, including but not limited to race or ethnicity or language proficiency, or in the case of older adults, just straight technological proficiency. I think we all run into this, the impact of ageism, that a lot of tools are simply not designed to be used by communities or people with lower tech literacy or so I think the issue of disparities created by a lack of proficiency in other, in addition to other determinants matters. And I think the point has been made consistently, and it's worth repeating yet again, that for digital health to really have the impact that we believe it can, no one should be left behind. And I think it's the community of people that are here, that attend this conference, that tend to be academically based, that bear the burden of making sure that everyone has a chance to use these tools, not just those that can access them or know intuitively how to use them. With that, we'll pivot to a different question. We've had a couple of comments and questions that get to the point of how all of you have converted your research participants or patients or clients who may be skeptical around virtual reality. And I think this extends also to clinicians, that sometimes you have to convert clinicians before you can convert their patients or clients. So let's touch a little bit on that. And maybe we can reverse the order of this one, going with Dr. Moore, then Dr. Sekhon, Trueba, and Preston.
Yeah, so I think for me, the biggest thing that I've kind of found beneficial to helping overcome some of that hesitancy. And this is actually something I learned during the height of the pandemic when I was actually helping my last VA establish a tele-neuropsychology clinic for assessment. I saw a lot of that same technological hesitancy then. Is kind of a two-pronged approach. One, from an interpersonal stance, me keeping it light and keeping it low pressure, and kind of setting the stage for the especially older adults to experience, hey, there may be technological issues. That's just fine. It's expected. If it is, don't worry about it. We'll find a workaround. It's just what happens. And keeping a positive attitude towards when they're stressed. You're like, yep, I'll let you know. Acknowledging that stress first off. Yep, it's a lot of different things that we're going to be asking you to do. It's something a lot of people haven't experienced, not just yourself. I would say most people haven't had the opportunity to do this. And if you're not good at it or perfect with it right away, we're not expecting that. We're just looking for you to have fun and see what happens. So I think for me, at least initially, being very open and honest about what's going on and what they're experiencing, checking in with them often, and kind of modeling and setting the stage for the kind of tone of the session they come in for has been really helpful for me.
Go ahead. No, go ahead, Anna.
On the inpatient unit, I think we've encountered the same thing, a lot of anxiety around doing it wrong or saying that they're not good at technology, because I think for older adults, they sort of have this general low confidence when it comes to technology. So a little bit, as Ian suggested, reassuring them that it's nothing they do can go wrong, really. It's more like an experience, and that if something goes wrong, they just have to let me know. And I think also, since we're on the inpatient unit and we're doing it in groups, sometimes I'll allow people to just test it, make it less serious, less okay, this is a structured intervention at the beginning, and just letting them try it. I give them a 10-minute sort of we're just trying it and testing it before we get into the actual intervention piece, can put patients at ease. And also facilitating and normalizing if they're having difficulty getting the headset on, that the headset is difficult to get on, get the straps on. If they're having difficulties with it, it's not because they're doing anything that's bad or, so I think that really has helped.
I think I echo exactly what Dr. Moore and Anna have said. I think, first of all, just being really open with them that, we understand it's the first time they're using this technology. We're going to teach them how to use it, encouraging them throughout the digital literacy component. And I really feel like Anna said, the first time, if they are able to really put on the device, get comfortable, adjust the strap, all of that before the intervention even starts. So if they can do that in this digital literacy kind of session, it really just helps alleviate a lot of the concerns that they have with, will I even know how to turn it on, and how does all of that work? And just giving them that kind of practice and comfort goes a really long way. And then, of course, telling them, that if you don't feel comfortable, we're really happy to stop at any point of time. If you feel sick or you just don't like it, that's a-okay. There's no problem. I think that really goes a long way as well, in terms of just, they don't want to also let you down, I feel sometimes. So if you just let them know that, hey, this is okay, that goes a long way as well.
Yes, everything that my fellow panelists have said, and then just adding in having good relationships with some of the providers that we're recruiting from. So some of the ones that we would get some of the veterans from, really having those strong relationships with them, where when they're presenting it to the veteran, or if they're mentioning it, if they have questions about it, you have that good relationship where this provider knows you, trusts the work that you do, and so they can let that veteran know, okay, well, I know this person. I trust some of the work that they do. I trust the work that they do. And if you have any questions, they're open to them, and really having that relationship there is helpful. And then I feel for some of our veterans also being able to have the caregivers present. So since we do ask the caregivers to come and provide assessments, they're also able to join in the experience and sit there while we screencast the experience. So that helps ease some of the anxiety as well.
Thank you. Let's move on to another question. Have you compared the impact of mindfulness meditation and the value add of virtual reality in comparison to just the television? And I know that you've spent some time thinking about that, so we'll start with you, and then we'll give the rest of our panelists a chance to chip in.
Yeah, I think, this is a debate, and it's also even a debate between mindfulness in the field of mindfulness, if VR is facilitating and making it easy, but then maybe it's removing that acceptance of reality, like you're removing yourself from reality, which is sort of counter what mindfulness is about, which is being more present. I do think for our patients, what I've observed, and obviously we need to do a lot more studies, doing like a very tight control, like randomized control trial, I think would be ideal to really tease apart how much virtual reality adds to this. I do think it helps patients and facilitates a lot of the processes of being in the present, especially when there's a lot of symptomatology and a high symptom acuity, because when you're struggling with so many negative thoughts and so many symptoms, it can be extremely hard to just focus on your breathing or do body scans or do a mindful walk because the symptomatology is so high. And in most mindfulness, manuals will say, like, if your symptoms are too high, it might be very hard to practice mindfulness, and you might have to wait until symptoms are lower. So I think with virtual reality, it might make it a little easier, even with high symptoms, to be able to focus in the moment, because it's such a stimulating environment that you're in. I also find that for our patients, especially our inpatients that are at the hospital, sort of bound there, some of them can't even go on the daily walk for various reasons. It allows them to get out of the context in which they are in, and maybe get them unstuck from some of these intrusive, repetitive, negative thoughts. But of course, this is all based on just patient reporting and qualitative sort of feedback. We really would have to delve into more controlled trials to really know how much the VR is contributing to this process.
Harmehr, would you like to go next?
Yeah, absolutely. I think it's the immersive nature of virtual reality that's really, in the way I see it, is for those who haven't yet practiced mindfulness or mindfulness meditation. There's a kind of a learning curve where you have to be, okay with being silent, and it's really difficult to do on your own and to initiate on your own. And that's where virtual reality may play a really important part, where it can just, the immersiveness of it may really help beginners. But like Anna said, we definitely need, and we would love to do in the future, even like a 3-armed study where we've got, virtual reality based mindfulness meditation, non-virtual reality based, and then like an active control. But that these are really important questions and ones, I guess, that we're hoping to be able to answer in the future.
Amie?
Anna and Harmehr have answered it perfectly and very beautifully. To me, it is feeling as though it's that immersive part of it. And for some individuals, for some people that maybe aren't able to watch the programs that they want when they want to watch them, this does lend for them where they have that opportunity to engage in the type of environment. Maybe they want more something that's a winter scene, but it's the middle of summer in Texas or in Arkansas where it's 100 and something degrees. So now I can relax in this environment, even though the outside environment, that's not the time of year for it, but I can control what type of environment is most relaxing to me at that moment.
So I'm sorry, Ian, any comments to add to that around just TV versus VR headsets for mindfulness?
Nope. My other 3 colleagues said it perfectly, and they're actually doing studies on that. My interest is more using it for cognitive purposes, so I'm going to let their words speak for themselves.
All right. So in the minute or so we have left, I'm going to ask a question. I believe we've made it through all of the questions there. Thank you for answering some of them in the Q&A box. I'm going to ask all of our speakers to go in order and give us about 10 or 15 seconds of which aspect of this is most exciting for them and what part of this they intend to focus on for, let's just say, the next year or so. So will everyone take about 10 or 15 seconds to say what's on your mind around VR and older adults? Dr. Moore, please go first.
Yep. So as I just kind of hinted at, my big goal for the next year is to actually establish a virtual reality cognitive rehabilitation program using various software on IVR. And in fact, I've got a few grants in with the Alzheimer's Association to do just that. We're in the kind of the final stages of that. So.
Awesome. Dr. Preston?
Yes, so in the future, I would like to look at using IVR to reduce agitation associated with cognitive impairment. So one of the best parts to me has been able to see the veteran's expression when they're using it, and then also the caregiver's expression, seeing how excited the veteran is. So that's where I want to focus in this next year.
Dr. Yepez?
I'm excited to see how this can work in different contexts. Obviously, I'm from Latin America, so for me, it's a big emphasis to see it, spread. I think what I like about it the most is what I just described, is seeing patients get unstuck. So oftentimes, older adults stop, their world gets smaller, so to speak. And I think virtual reality is a way of opening up their world so that those intrusive, repetitive thoughts that they have, it gives them something different, a stimulus that might get them unstuck from that a pattern and open their world up. So I think that's what gets me most excited.
And Dr. Sekhon?
Yeah, I think for me, what's really exciting is to kind of take what we've done here as a pilot and apply for funding to be able to do a full-scale RCT. I'd also love to kind of expand our work into older adults with dementia and also those experiencing more significant mental health conditions. I think that's where I'm really excited to be working.
Well, thank you to all of you for, first of all, your work and for joining us and presenting today. We will wrap up this session now for all of our attendees. The next session is our wonderful keynote by Dr. Christine Umuke that will begin at 12:15. We will be closing this Zoom meeting, and we ask everyone to return to the conference platform from where you will be able to access the next session. It will start in just about 15 minutes. Thank you so much. Have a wonderful rest of TIPS and have a wonderful day.